Hey everyone, welcome to this episode of the Chad G Ortho T podcast. I'm your host, Chad Guerrero. It's been a little while since I've recorded, my podcast episodes. It's been maybe even a year, could be longer since I've done that. I've really been working on my social media, my YouTube channel, Instagram, all that, just trying to create a lot of social media content. Also working on my clinic, which my clinic has been super busy this past year. Very thankful for that. And so just kind of what I've been had going on, and haven't had a chance to record any more episodes. And honestly, I changed the recording software that I'm using, so it's a little different. It's difficult for me to kind of figure out a little bit, which I'm still figuring it out. So it's a little difficult to figure out and see, how this kind of how to operate it and upload and edit and all those things. There's so much goes into that. And so anyway, so here I am now. I'm super pumped about my YouTube channel. I started back in, I think, September, around 177 subscribers. And I just checked today and I have over 45,000. So I'm pretty pumped about that. That's incredible. So if you follow me or subscribe to me on YouTube and watch my content, thank you so very much, because you're part of that number. I do appreciate it. And so if you're watching this on YouTube now, wherever you're listening from, from whatever platform that is, thank you so much for listening. Today, I'm going to go over a little bit about bicep tendinitis or tendinopathy at the shoulder. So this is a pretty common area for people to have complaints. I recently suffered this myself. It's kind of why I wanted to go over it. Kind of what is it, and then what are some treatment options for it? What do you need to do? And, again, very, very common, mistaken a lot of times for rotator cuff issues, although I will typically also treat the rotator cuff as far as the exercises and stretches whenever I treat a bicep tendinopathy in the shoulder, just because it's all so close and their functions are all very similar in some aspects. And so I just kind of want to make sure that everything's functioning in the area properly. So a little bit of anatomy in the upper arm. So from the elbow to the shoulder, we have several muscles on the front compartment of the anterior compartment. So if you kind of go from the humerus bone forwards, you're going to have the coracobrachialis muscle that's in there. The brachialis muscle. So if you're doing like hammer curls at the gym, those hammer style curls, and we have the forearm, like a neutral position, that is targeting the brachialis muscle a little bit more. The brachioradialis, if you do reverse curls at the gym where you grab the bar, palm side down, kind of see that palm side down and do those exercises that way of curls, that's working the brachioradialis. And then we're gonna have the bicep brachii or brachii. So that's the one on top that a lot of people think about. Hey, make a bicep where you're, that kind of egg or that peak portion at the top of the arm up there. And that muscle has two heads. It has a short head and a long head. So the short head is on the inside, so it's closest to the body, to your torso. And the long head is on the outside portion of that. Now they kind of attach to the same tendinous area at the bottom where it attaches in the forearm past the elbow. But now going up towards the shoulder, that's where it gets a little tricky. So the short head goes over and attaches to the coracobrachialis, or I'm sorry, the short head goes over and attaches to the coracoid process. And the coracoid process is a little bony kind of part that kind of protrudes out from the scapula of the shoulder blade. And then the long head is going to travel up, go through the kind of outside, if you can kind of see this on, if you're watching the video, but it goes on the front portion of the shoulder, a little bit on the outside. It goes through something called the intertubercular groove. And that groove goes between the tubercles of the humerus bone. And now that tendon's going to go into the joint, and where the ball fits in the socket or the humeral head fits into the socket, it's going to attach on the top portion of that rim of what's called the glenoid fossa. So the glenoid fossa is the depressed area on the shoulder blade of the scapula, and then that humeral head comes in, the bicep tendon comes up and attaches at the top. Now, you can have irritation where the tendon goes through the groove. In that groove, that can become a tenosynovitis, where the synovial sheath, there's kind of like think about like a sheath or a covering or a piece of pipe, that the tendon travels through. If it were a pipe and a rope, and the rope with the tendon passes through that pipe, and that can become irritated with inside the pipe area, so to speak. It also can become irritated, torn, frayed at the attachment point at the glenoid rim there on the inside, the top. And so a lot of times patients complain of pain in the front part of the shoulder. Maybe it radiates down in the bicep. I have seen it radiate down in other parts of the arm, around the shoulder blade and all. But that's not that common. At least it's not been in my experience. And you go through all the testing. Now, my thoughts on clinical orthopedic tests, there's a lot of debate on that. How effective are they? How accurate are they? So I just go through a whole battery of those. I'm going to check the rotator cuff. We're going to check the labrum, that collection of fibrocartilage in there that makes the joint space a little deeper. It kind of creates a joint space, the labrum does. And then the rotator cuff tendons and all that's on top of that. So I'm going to check all that. And then we're going to go through some bicep testing. I'm going to do what's called a bicep load test, a Jurgensen's test, a speeds test, and I also perform a dynamic speeds test. So just to try to pinpoint a little more about what's going on or where the location is. And the biggest thing is patient history. That a patient may tell me um, they were doing something in the yard. I actually had someone that picked up on a heavy bucket full of things, and when he picked it up, then it tore at the shoulder. And you're going to notice if you have a complete tear where that tendon tears off the rim, then you're going to notice like all the bicep material here, the muscle is going to bunch up. So if they make a bicep and it bunches up down here towards the elbow, and there's this big gap or space from the middle part of the muscle up towards the shoulder, and definitely if it looks disfigured as compared to the other side, the other arm, then you probably do have a tear. You may notice bruising, and again, pain with that. The patient may feel or hear a pop or a click or a snap in the shoulder. A lot of patients know that they know what they did when they done it. Like it's very obvious in a lot of cases because you may have difficulty raising your arm. That muscle, the bicep brachii, not only does it flex the elbows, it brings the hand closer to the shoulder, like in a bicep curl, but then it's also going to supinate the forearm. So if your hand is palm side down and it contracts, there is a muscle called the supinator muscle, but also that bicep brachii, because of its attachment point, is going to help to flip your palm side up. So it's going to do that. It also is going to help to flex the shoulder because it crosses the shoulder joint. So it's not the main muscle that does that, but it is going to help. So if you raise your arm up in the front, that long head, the bicep, is contributing to that movement. One of the other things that it does that's very similar to a rotator cuff muscle is it helps with a little bit of humeral head depression. Now, as far as how much, I'm not sure. I've seen research on this, different amounts and different opinions on this. But because of it crossing over the top of the humeral head and going into the joint, it can kind of help to keep the humeral head as it sits in the socket kind of centralized, keep it from riding up as much. And that's part of the function of the rotator cuff muscles, is to keep that humeral head centralized and kind of stabilized in the center of the joint. So it can have some contribution there. So that's why whenever you have damage there, or a tear, or if you had surgery, I'm going to go ahead and put you through also rotator cuff exercises, rotational things of the shoulder, scapular stabilization, motor control exercises and activities. All those things are important to make sure that you cover to heal everything properly. If you just have a tendinopathy where it's just inflamed, you don't have a tear, a lot of times patients or people just want to go, very passive, just put ice on it or heat or a TENS unit, and all that stuff is great and it does feel better. And if it allows you to be able to participate in exercises and functional movements and all that, then that's fine, because the goal of everything needs to be to load the tendon. I'm going to put it under a load. So that's whether it's bands, body weight, dumbbells, whatever you're using. You want to put it under, start light, and then progress with the amount of resistance and load that you're using, and in order to promote proper healing of the tendon. And so you want to make sure that you're doing that, because just passive, going completely passive, let's say you have a baseball pitcher and they develop tendonitis there, tendinopathy there, and the recommendation is rest in ice for 2 weeks, don't do anything, and then they go right back to throwing. There was a huge component that was missed. Number one, that tissue was not loaded properly and retrained. You did not grade or perform graded exposure back into throwing. That's whether it's just the movement or initiate a throwing program, etc. And I see that a lot with patients, and they kind of, maybe they get discharged from the doctor, the therapy, and they're like, well, you're good to go. Well, you're missing a big portion of what needs to be done. And you don't have to be a baseball player or athlete for this. You want this to be, everything to be where it needs to be and appropriate. Even if you're just at home, you're working out in the yard, you're just doing stuff around the house, whatever that is, you want that to function at an optimal level. So you want to make sure that if you have a little tendonitis there, tendinopathy or irritation or whatever, you want to make sure that you are performing some strengthening and graded resistance exercises in that area to promote proper healing. A lot of people ask, how long does it take to get over? Everybody's different. Mine took about 3 weeks or so, maybe 4 weeks to get over. Mine wasn't super severe, and I didn't let it rock on for a long period of time. If it has been going on for longer, sometimes that can take longer to treat. You can develop things like calcific tendonitis, where you get or tendinopathy, whatever you want to call it. Everybody calls it something different now, but it can be a little more difficult to treat. And so definitely want to jump on it, sooner rather than later. So anyway, thank you so much for listening. I hope that that information helps. That's just a little bit about long head bicep tendinopathy, that pain, the front part, the outside portion of your shoulder, and then also a little bit about kind of what I've been up to. Thank you so much for watching or listening to this podcast, and I will see you guys next time. Thanks so much.